Our next speaker is Dr. Reshmie Ramautarsing, who is the Program and Technical Director at the Prevention Unit of the Thai Red Cross AIDS Research Center. Reshmie leads all key population-led health services activities, as well as oversees all PrEP projects under the Thai Red Cross AIDS Research Center. And recently, she has also focused her interest in the use of PrEP cascade in order to monitor PrEP implementation and identify gaps for improvement. Reshmie will be talking to us about the Thai Red Cross experience with PrEP and overall PrEP program in the country.
Thank you very much, Nitya, for that introduction. And I would also like to thank the organizers for the opportunity to come and talk here today to you about our experience with PrEP implementation in Thailand. So this is what I will do. I will talk to you about two programs of PrEP implementation. The first one is Princess PrEP, which is a free KP-led PrEP program, which has already been mentioned a couple of times. PrEP 15, I will also discuss briefly. Then I will talk about the current coverage of PrEP among key populations in Thailand, say a little bit about scale-up of PrEP, and then I'll leave you with my conclusions and take-home messages. So let's talk about Princess PrEP. In Thailand, two key populations are disproportionately affected by HIV. Men who have sex with men and transgender women account for more than half of all new HIV infections. So to improve the uptake of HIV-related services among these populations, we implemented the key population-led health services model, through which trained lay providers, who themselves are members of the key populations that they serve, provide services along the HIV cascade. So they provide, they do outreach and recruitment activities. They bring people in for HIV counseling and HIV testing in the community-based clinics, thereby enabling them to identify populations with extremely high HIV prevalence and incidence. For people who are HIV positive, they are linked to care immediately on the same day where possible. And for those people living with HIV who are stable on ART, the CBOs and the KP lay providers are able to provide differentiated ART maintenance services by providing ART pickups in the CBOs. And for people who are HIV negative, the KP lay providers are able to dispense PrEP or PEP to the clients at risk for HIV. Integrated into that model are also services like STI testing and hormone monitoring services for transgender people, as well as the assist screening to detect and address substance abuse among the two key populations. So the PrEP part of the program we refer to as Princess PrEP, because this Princess Somsawali HIV Prevention Fund is used to procure the drugs for the program, and it is a partnership between several partners coming together and enabling trained and certified KP lay providers to provide PrEP. So the KP lay providers perform all the acts in PrEP dispensing. They start with performing the risk assessment and PrEP counseling. They do the HIV testing by themselves, and they take the samples for hepatitis and creatinine testing, send them to outside laboratories. Then they dispense PrEP. They give a bottle of PrEP to the client to start on the same day for those clients who are HIV negative, based on a doctor's standing order. A couple of days later, once the additional lab results are in consultation with the doctor, they communicate with the client about their test results, and then they keep on providing PrEP and follow-up visits for these clients. So this program started in 2016, and this is the latest updated data that I have. From the beginning of the program until the 31st of December last year, the program has provided PrEP to more than 6,000 cumulative PrEP users. So now I'll show you some data on the PrEP uptake cascade. So for this, we looked at people coming in to the clinics between June and October last year. So this is for 5 months. And we wanted to see how many people are at risk and accept PrEP. So we saw that in that period, we start with MSM, we saw that 7,000 MSM came in for HIV testing, 94% of them were HIV negative, 2/3 were assessed to be at risk for HIV by the counseling session, almost everyone was offered PrEP, and 1/3 accepted PrEP. So then we looked at people who did not accept PrEP and asked them why not. And what we see is the main reason for not accepting PrEP is saying, I'm not at risk. It's about 40% who say that. We see a similar picture for transgender women, about 1,000 in that 5-month period. 96% were HIV negative. Again, about two-thirds were at risk for HIV. Almost everyone was offered PrEP. And 36% accepted. And 30% of those people who did not want to start PrEP also said, I'm not at risk. So when we zoom in a little bit on the actual reported risk through which clients were classified as being at risk in the cascade, we see that among people who say, I'm not at risk, 50% report not to use condoms during intercourse. Among those people who say, but I always use condoms, 50% report multiple partners in the last 30 days. And among those people who say, I'm not interested, 75% report condomless intercourse. So clearly, there is a high risk among these people. The risk is just not perceived as such. So let's look at retention in PrEP care for men who have sex with men. As you can see, retention is suboptimal. Here we look at the retention at each PrEP visit broken down by age. And as you can see, there's already quite a bit of a drop-off at month 1, which continues over the following visits and is highest among the youngest clients. And we see a similar picture again for transgender women with an overall retention that is lower compared to men who have sex with men. So one of the things we then did is examine our service flow. And here, so we did that for most of the services within KPLHS, but what I'll show you here is the flow for the PrEP follow-up visits. And in the old flow, it took more than an hour to come in and get your HIV test and get your PrEP medication and be on your way again. Between registration and questionnaires and then pre-counseling and then blood draw and waiting and post-test counseling, getting your drugs. It's a long time for young, healthy people who have people to see, places to be. And we really also started to think about, do we really need to do the same pre-test counseling and the same post-test counseling for those people who we see every 3 months? So in partnership with our CBO partners, we then came up with an express flow inspired by the Dean Street Express for PrEP refill visits. And this is for clients who don't have symptoms, who have good self-reported adherence, and who don't have any questions or issues that they want to discuss with the counselor during that visit, and as much as possible is done online. And in the actual clinic, the appointment is confirmed. We do a bit of pre-test counseling. We give them the PrEP and make the next appointment. Then they draw the blood and they leave their contact details as well as their preferred method of communication for their test result, and they can be on their way. So this express service from beginning to end is only 20 minutes. And this was implemented last summer, and about 800 people were eligible for this express service, and everyone accepted it. And we did a short satisfaction survey. What we saw is that people were very, very happy, and they actually preferred this express service over the regular service. So next I will talk a little bit about PrEP 15. PrEP 15 started out as PrEP 30 back in 2014 to reflect the cost of 30 baht per day, which was reduced to 15 baht per day for the whole package of PrEP services, which includes the medication, the testing for HIV and hepatitis and kidney function monitoring. And this is a fee-based program which is implemented at the Anonymous Clinic here in Bangkok. And here you can see from the start in 2014 up until the end of the year, the cumulative users in PrEP 15, in the light blue top part of this graph, is about 4,200 people. And together, these two programs account for more than 10,000 cumulative PrEP users in Thailand. So then when we look at contributions of all Thai PrEP users in the country by program, we see that Princess PrEP accounts for almost half of those PrEP users. PrEP 15 a third, which is one single-site fee-based program, can actually contribute 34% to all PrEP users, and then 18% is contributed through the Ministry of Health, Ministry of Public Health program, implemented in various public health hospitals within the country. So this is we're now at 11,300 cumulative PrEP users, and that's really great. It's, I think, in the region, one of the best so far. But when we compare that with the national PrEP targets, it's only 5% of those people who are at risk for HIV and who actually should be on PrEP. So let's take a minute to use all this data as well as the national PrEP target data to look at the current coverage of PrEP among KPs in Thailand. So we use the HIV prevention cascade framework to plug in all this data and look at the coverage and effective use. So if you're not familiar, the HIV prevention cascade is a framework that allows you to examine an HIV prevention method, and by using a cascade form, you can see between each step of the cascade where the gaps are, why the gaps are there, and what you can do to improve your services. So you start with the priority population, which is everyone that can benefit from the specific intervention that you're going to look at. Then you look at motivation, which is demand. Who wants to use it? Who wants to use your PrEP or condoms or whatever you're looking at? Then you're looking at access of those people who are a priority population and who have demand. How many can actually access it? And then you look at effective use. How many are actually effectively covered by an HIV prevention method? So you can do this as a 90-90-90 cascade, where the denominator for each bar is the number from the last bar. But we did it as every bar was, the denominator for every bar was the main priority population, to really show of all people who are in need of PrEP, how many in the end are effectively covered by PrEP. So this is the result for the MSM. So I want you to focus on the blue bars here first. This is in priority provinces in Thailand. We used the UNAIDS PrEP targets and saw that in those priority provinces, 97,000 MSM are at risk for HIV and could benefit from PrEP. We used the uptake data from Princess PrEP and plugged that in and found that of those people, about 20,000 people would accept PrEP when offered. Then looking at current PrEP access through Princess PrEP in those provinces, 3,000 of those were actually using PrEP, which is 3% of the entire priority population. And then we looked at effective use, which, to be fair, we did quite a strict definition for that, which was for MSM, 4 or more tablets per week, but also coming back for visits, for every visit during a whole year. And then we found that of all those 97,000 MSM who are at risk, 1.3% are effectively covered by PrEP. So there's obviously a huge gap. We examined the gap, the first gap between the targets and the demand, and this is the same as the program data that I showed you. The main reason for not wanting PrEP is people do not see themselves at risk. And then the pie charts show you that those people who do not see themselves at risk, or say I use condoms, they have very high rates of the blue, which is multiple partners, or green, which is condomless intercourse. So for the transgender women, very similar picture again, with about 8,000 transgender women in the priority provinces at risk for HIV and would benefit from PrEP. With the current demand and uptake data, about 1,800 of those would actually accept PrEP when offered. And of those, currently about 530 are actually accessing it, which is 7% of all transgender women at risk for HIV. This was, the effective use was even lower, with less than 1% of transgender women being effectively covered by PrEP. The reasons for not accepting PrEP and the mismatch with the risk behavior here is the same as what we saw for MSM. So then we also looked at the second gap, which is between demand and access, and tried to see what an additional program, a fee-based program like PrEP 15, could contribute to that. And we have to zoom in a little bit because it's a scale of 100%, so it's difficult to see. But what we found is that PrEP 15 actually increases the access by 50%. Nevertheless, the gaps are still there and remain big, and PrEP coverage is not what we need it to be, nowhere near what we need it to be. So why do we then need to scale up PrEP? I think we all know, or we should all know, that universal treatment alone will not have an impact on the epidemic. And adding PrEP to universal test and treat can really significantly increase the reduction that we see in new infections. So this is New South Wales, where they had already reached and even exceeded 90-90-90, and by introducing PrEP rapidly and massively scaling it up, they've seen a very impressive decline in new HIV diagnosis among men who have sex with men. And in settings where treatment and PrEP were scaled up together, like London and as places in the United States, we see the same trend. So as Dr. Towisap has already mentioned, Thailand is now in the pilot phase of PrEP under the universal healthcare with an initial slot of 2,000 people being covered, about 40% of whom will be enrolled from the key population-led program. And this is great progress, and it's a result of very hard work, very dedicated people. But when we look at the target, I think we need to realize that we need to think bigger and more out of the box to really get to the targets and to really see an impact on the epidemic. So I want to talk a little bit about messaging. As we have seen, risk misperception is one of the most important reasons for people not to start PrEP. And we have to be very careful about how we formulate our PrEP messages, not just in campaigns or educational materials, but also as providers, how we talk to our clients. If we focus on risk alone and we say, you're at risk, you have to see your risk, you need to be on PrEP, that is not effective for those people who do not see themselves at risk. And what you actually then risk is alienating those populations, which can really negatively impact the uptake of PrEP in those people who can really benefit from it the most. So instead, we should focus on gain framing our messages, meaning that we should focus on health and success and protection and pleasure with positive messages in campaigns, in educational material, and the way that we speak to our patients. This is about you being healthy and being able to enjoy your life. And this is a mock-up for a campaign that we're going to initiate in Bangkok later this year called PrEP in the City, which is using that exact approach. It's centered around beauty and feeling good and taking care of yourself to increase the PrEP uptake among transgender women. Another approach we are taking is partnering with private clinics and hospitals to further expand PrEP services. As we've seen from PrEP 15, there is quite a significant segment of the population that could benefit from PrEP who is not only willing but also able to pay for PrEP services. So to tailor to this subset of clients, we now have two partnerships, one with PrEP Hospital, which is a private hospital here in Bangkok, and one with Safe Clinic, which is a private clinic here in the center of Bangkok as well, to provide HIV-related services, including PrEP, and we're looking at other private partners to team up with to provide these services. Finally, I know that Dr. Don is going to talk about this as well, but I really think this cannot be said enough, and I want to show you program data from us as well. This is prevalence of STIs in HIV-negative MSM and transgender women from two cohorts, one a hospital-based, one a community-based cohort, enrolled in 2012 to 2016. So this was when PrEP was at the very, very first stage in Thailand. So almost no one of these people were actually on PrEP. And what we see that there was already a very high rate of STIs with 5% of syphilis, up to 12% of gonorrhea in any compartment, and almost 20% of chlamydia chlamydia in any compartment. And I just want to say that this should be, PrEP is really an opportunity to address this. We shouldn't say because of STIs we're not going to do PrEP. That's false reasoning, and we should really shift away from that because it's dangerous. So instead, we should use our PrEP programming and add STI services in that to really target those really high STI burden clients. So what we have done, we have integrated point-of-care testing for chlamydia and gonorrhea using the Gene Expert machine into our KPLHS model, and we're using pooled samples from 3 compartments to save costs, but also to avoid missing any infections if you only select one compartment for screening. And from the preliminary result, we see that a very good agreement for pooled samples, 100% for chlamydia and 98% for gonorrhea. And this could really be a solution to start targeting and addressing the high STI rate in these populations. So I'll end with this. As we've seen, we really need a wide variety of service delivery model to fit different needs and lifestyles. Like Dr. Tosh said, you don't need a fancy clinic to start with PrEP. You can just start using what you have. And this also provides opportunity for expansion. Low uptake of PrEP among key population is seen. There's many reasons which are beyond the scope of my talk, but here we talked about risk misperception, and I really want to reiterate that we need to focus on health in our messaging, in our education, and in our conversations with our patients, not on risk. We've seen suboptimal retention. I think we really need to think about how we're going to define retention. We don't really need to look at 12 months of retention for people on PrEP. And there's things that you can do in your clinic, like looking at your service flow and thinking about how you can improve that to fit the needs of the clients that are coming to you. Scale up is very urgently needed if we want to see an impact of the epidemic, because treatment alone is not going to get us there. And this also provides an opportunity for addressing high STI burdens that we see. Thank you very much for your attention.